Sasha Couch. I met her, I don't know, 5 or 6 years ago. We happened to be at a conference. It was another type of conference, nothing related to kidney disease. And we were standing in line to go into something, and I started chit-chatting with her. And then she said, oh, I'm on dialysis. The whole kidney thing came out. And then I realized she was a winner in our essay contest and wrote an incredible essay. And you just need to put her name in the website, Sasha, and you'll be able to read it. And we've remained friends, and she's an incredible advocate, very knowledgeable, and she knows her stuff. So I'm really happy and thrilled that, Sasha, you're here today. So I'm going to turn it over to you.
Thank you, Lori. And hi, everyone. I'm very excited to be here today. I hope that you've been having a great time at Hope Week, and you've learned a lot of things that you can use in your everyday life. And so I'm going to talk a little bit about insurance. I am not an insurance expert by any means, but living with kidney disease, I've certainly had to navigate many arenas that involve insurance, going through the trajectory from pre-dialysis to transplant to post-transplant. So I am currently 4.5 years post-transplant. I received a kidney and a pancreas. So all of the different stages of kidney disease, as many of you know, I'm sure, require different steps when it comes to insurance. And you definitely have to be prepared to know what you can do to be your best advocate. Or if you're a caregiver to the person with kidney disease, to be that person's advocate, because our best advocates are always going to be ourselves, and we need to be armed with information. We need to know the right questions to ask, and we need to know not to be afraid to ask any questions, because all of this is super important. These are our lives. So, we get rid of fear. Ask no such thing as a stupid question. Ask as many questions as you want. So I am going to share my screen and pull up some slides. And I'm just going to kind of incorporate my story and the things that I've had to deal with as I go through the slides. Oh, and I have a tendency to get off on tangents, but I'll try to control that so I don't run into Cher's time. So here we go. Let's see here. Okay, so. I can't see. Let me get rid of this. I can't see here what I need.
I think you have to put slideshow play.
I do. I can't get there because of the, here we go. I had to move all. So let me just move that.
From beginning over to the left. You got it. And now I think Sasha's on mute.
Okay, here we go. Here I am. I'm back in view. I'm off of mute. Okay, so a lot of this is going to be old hat, depending on what stage you're in. But the first thing I'm going to talk about is the very basic, who's eligible for Medicare. So if you are on your end-stage renal disease, your kidneys no longer work, and you need dialysis, or you've had a kidney transplant, you are eligible for Medicare. Now, that is based on whether you have worked the required amount of time, or you're part of the Railroad Retirement Board, government employee, or you're already getting Social Security benefits or railroad benefits, or you're the spouse or child of someone who fits that criteria. Now, luckily, a few years ago, the age was expanded. So now you could be up to 26 and get covered by your parents, which is super helpful. And in the case of ERSD and going on dialysis and moving into the transplant process, that's even more helpful. So I will say that my personal story, I actually didn't have a lot of time to prepare for going on dialysis. I hit end stage renal disease very quickly, and I was put into the hospital after an emergency doctor's appointment. So I didn't really have time to prepare to navigate my way through what questions I would ask, when should I apply for Medicare and all that kind of stuff, because I was just thrown into it very quickly. I live in California, and actually I live by myself. Most of my family is out of state. So really I had to deal with the beginning stages all on my own. So that was, and when you are thrown into the hospital, you first get on dialysis and it all sort of happens at once. The last thing you're thinking about is insurance. I have to say that was definitely not at the forefront of my mind for that first week or two. So if you are in a stage where you're stage 4, maybe, that you're going to have to go on dialysis, you should probably get yourself prepared, ask all the right questions, so you know what's coming. So let me move on here to the next slide. So, oops, let me go back. Okay, so let me make sure that I am in the right. Okay, so if you want to enroll in Medicare, if you're eligible for Medicare because you have end-stage renal disease and you qualify for Part A, which is the hospital insurance, you also get Part B, which is the medical insurance. But you'll need both if you want to get the full benefits. And you want that to be able to cover your dialysis and then eventually your kidney transplant. So what you should do is you should go to the Social Security office. If you have questions, if you don't know if you qualify, if you're not unsure about anything, call your Social Security office or go into your Social Security office. Or if you're at a dialysis center and there's a social worker, make sure that you ask the social worker any questions that you may have. Or if you're advocating for a family member, be sure to ask the social worker whatever questions that you have. I do know that it varies across centers how much your social worker may know. Unfortunately, there isn't like a baseline. So nationally, we have the same quality social workers across the country. Where we are, in particular, California, LA County alone has 160 dialysis centers. And California has over 19,000 people waiting for a kidney donation. So we are definitely a dense state. We have some centers that are rural. We have urban centers. We have suburban centers. So it's there's a vast difference across that. So if you feel like your social worker isn't answering all your questions, definitely find someone that can. Go to your nephrologist's office, get in touch with a kidney organization like Renal Support Network. They're a great resource and they can answer your questions. Or if they can't answer your questions, they can guide you to somewhere that can answer your questions. So anyway, the rest of this just briefly says, if you apply and you're approved, you won't get any penalty for Part B, because sometimes there's an enrollment penalty, but if you have ESRD, that will be waived. Okay, so what does it cover? I'll try to get through this very quickly, but it's going to cover, inpatient dialysis treatment. So your dialysis treatments are covered, home dialysis training, dialysis equipment and supplies, some support services, most drugs and other services and supplies that are part of dialysis, lab tests. When you're traveling and you want to do dialysis, it will also cover that. Now, it does depend on your region. There may be some variation. So if you have a question about anything that might not be covered, always know who you can ask. When you do get enrolled in Medicare, you actually should either sign up with Medicare Online if that's available to you, if you're well versed in technology. So then when you have an account, it's easier when you call or you can chat. You can just talk to someone on the web anytime you have questions. And you want to make it as easy for you and as accessible for you as possible. So this is a little chart that I made about might help. Sometimes some people have some questions about if you already have insurance and you're just entering dialysis, what your options are. So whoever the person is that has chronic kidney disease, say, for example, you have ACA coverage. If you have ACA coverage, you do have the option to keep that coverage. And then you can also apply for disability insurance if that applies to you, or Medicare. So, but what that may do is if you keep ACA and Medicare, you're going to lose the subsidies that come with your Affordable Care Act coverage. So if you have questions about that, definitely you should call Social Security or call ACA or Medicare, and they should be able to answer those for you. Now, if you decide, you know what, I'm just going to go on Medicare, I'm going to stop my ACA coverage, then you can apply for a supplemental insurance. So you'll have Medicare, but then you're going to need a supplemental insurance because that will cover, Medicare will cover 80% for the most part, but then you'll still have 20% that you're going to need to cover. So you're going to want to have a supplemental plan. So that, chart's pretty clear. You're just going to want to have something that covers that. Now, if you have current insurance through your employer, you have two options. Now, when you first start dialysis, you may not know if you can keep working. Dialysis, as many of us know, depletes your energy. You may not feel like working. You may not have the capacity that you thought you had. Or conversely, you might be able to work more and you had no idea that you'd be able to both do dialysis and work. So sometimes you have to figure out your situation as you go along. If you decide to keep working, you can enroll in Medicare, and that will become your primary insurance, and that's going to be after 30 months. And your employer insurance will become your supplemental. But then you're covered between what you get from work and Medicare. You should be covered. Maybe have a few extra extraneous expenses, but otherwise that should work for you. Now, if you can't work, if you stop working or you can't work, you can have Medicare and then apply for a supplemental insurance. It's sad because a lot of people in our community run into an issue where they make too much to get, say, for example, Medicaid. Say they wanted Medicaid as their supplemental. Here in California, we call it Medi-Cal, as many of you likely know. But say you make too much for Medi-Cal, but you don't make enough to actually afford a decent supplemental insurance that's going to cover the difference. Well, kind of in a bind. And sadly, a lot of people in our community have actually stopped working so they can actually afford to pay for their dialysis treatment, which seems counterintuitive, but until they figure out how to cover us in a way that's overall and works for everybody, we're just going to have to do what we have to do. Now, luckily, more people are going to be eligible for Medigap. Medigap, as some of you probably know, is a plan that kind of covers the gaps in coverage. So right now, 26 states allow people who are under 65 and ESRD patients to get Medigap. You can apply for Medigap. The number of states that allow Medigap is expanding. So hopefully soon we'll have a lot more than 26, especially with everyone trying to move to home dialysis. And that's a whole nother issue. But with the executive order that was signed 2 years ago, they're trying to move more patients to home dialysis and to get transplants. So with that will come expanded health coverage, hopefully, for people in our community. You can get COBRA as well as supplement. That you'll have to ask about with your job. So moving on, at some point, so for me, dialysis was, I figured out my insurance fairly quickly. I was self-employed at the time, and I what I ended up doing is getting onto Medicare, and Medicare also is retroactive. So if you have an employee, if you're using your employer health care, they will probably have to cover the first month, and then Medicare will start within 4 months. So 4 months, but it does go retroactively. So the most that you would be responsible for, or your employer coverage would be responsible for, would be the first month. So Medicare is retroactive up to a year. So you have up to a year to apply and have your dialysis covered. So I was good with my plan. I got Medicare, and then I used the policy I already had that I was actually paying for because, as I said, I'm self-employed, which is already very expensive. But, I kept that. So that did me well through dialysis. But once I got to the point of transplant, that brought up a whole nother set of questions. What's covered now that I was going in for transplant testing and, through the transplant process and then beyond that. So as far as Medicare goes, Part A will cover inpatient services, the kidney registry fee, lab tests, and other tests to evaluate, your condition for transplant, the cost of transplant surgery, and the full cost of care for your donor if you have a donor. Now, right now, there's legislation for more coverage for living donors to actually make more people consider being a living donor. It's called the Living Donor Protection Act, because besides what Medicare will cover as far as labs and that type of stuff, there are other expenses that donors have to deal with, whether it's, say, your cousin wants to donate to you, but they live a few states away. There are travel costs, there are extraneous costs like eating, if they drive to get to the hospital, meals and taking off of work and all of that. Right now, that's not covered as much as we would like it to be. So with this Living Donor Protection Act, we're hoping that living donors actually get more coverage so that more people will want to be living donors. And if you have a living donor, kudos to you. That's amazing. And you are in good shape. Okay, so also it will cover any additional inpatient hospital care for your donor in case of problems and blood transfusions. So there's that. Now, what Part B will cover, it'll cover doctor services for the transplant and also for your donor. Transplant drugs are immunosuppressive drugs. As most of you know, likely, transplant is not a cure. Transplant is another step in this kidney journey. If you are a person living with kidney disease, you will always be a person living with kidney disease. Transplant allows us to have a life that's fairly normal, but it is not a cure, and we will be on immunosuppressive drugs for the remainder of our lives, or until they come up with some amazing way where we don't have to be, which hopefully they are researching right now as we're in this meeting. But for now, we will have to take immunosuppressive drugs until. So that's also something we have to think about in terms of being able to afford immunosuppressive drugs for the rest of our lives, and Medicare ends 36 months after the date of your transplant. So you have to figure out, once you get transplanted, you have to take the steps to figure out how you are going to cover your immunosuppressive drugs. So you want to make sure that you have a plan in place for when Medicare ends. Sometimes people don't think about that. And I have talked to a couple of people who weren't exactly prepared for Medicare stopping and being able to afford their transplant drugs. And that does really vary across plans. So if it's your employer plan or if it's your spouse's plan, you really need to look into that and make sure that you're going to be, if not fully covered, which, you're going to probably have some expense, you want to be sure that you're not surprised by how much you're expected to cover. Blah, blah, blah. I know. I'm talking. anyway, that worked out for me in the sense that when my 36 months was over, which was about a year and a half ago, I went back to the plan I was using as my supplemental plan and made it my main plan. It's still very expensive, even more than it was, but as long I'm covered and I do get my meds to keep me alive. So that's the goal, right? Okay, so now what a lot of people are talking about, you might have heard someone talk about this, whether at your dialysis center or your nephrologist may have mentioned it, is Medicare Advantage. The Medicare Advantage, which is also known as Part C, Medicare Part C, is a private health plan. And starting in for a long time, they didn't have kidney patients eligible who are under 65 eligible to receive Medicare Advantage plans. In January of 2021, it was finally approved that kidney patients, people on dialysis, people who've had transplant, are eligible for Medicare Advantage. So if you're enrolled in a Medicare Advantage plan, you are going to receive the same benefits offered by original Medicare, but the rules and regulations can be a little bit different. Now, a benefit is you will also get things like eye care, dental care, routine dental care, hearing aids, prescription drug coverage, fitness center. If a nurse has to come to your house, generally that's covered. Again, this varies by the plan that you choose and also where you're located in the country. The problem comes in, some people, it's not a great option because depends on where you live. If you're in a rural area, this might not work for you. Sometimes your doctor who you've had for a very long time may not be in network. It's a bundled care plan. It's thought of as like a one-stop shop for all your health and prescription drug coverage needs. So it's a bundled plan, which means that you don't actually have a choice of who's in network. So you want to be sure that if you want to keep your doctor, that your doctor is in network, and any specialists that you either go to now or that you might want to go to are also included in network. So it's sort of like you may have to give some things up to keep some things. So it's hit or miss. You have to figure out whether it makes the most sense for you, but they are definitely looking to get more people onto Medicare Advantage plans within the next 5 years. So it contracts with the government. So the government is going to pay a fixed amount per person to provide these Medicare benefits. So what it will cost you, you'll still have to pay a monthly premium for A or B. There are going to be, as I was just sort of talking about, different rules and restrictions for each Medicare plan. But it can be less expensive, and that's part of why a lot of people are moving over to Medicare Advantage plans. You are going to have to enroll in a standalone Part D plan. Part D is the prescription part of Medicare. But depending on what plan you get, that can all be explained to you, when you ask questions about Medicare Advantage for each different plan. What it does do that's great is it lessens your out-of-pocket expense. So with regular Medicare, there's no out-of-pocket cap for your expenses. So theoretically, your expenses are endless, limitless, depending on special circumstances, or you might end up paying a lot out of pocket that you didn't foresee. But Medicare Advantage plans do put a cap on that. So basically, the overall outlook on Medicare Advantage is that it can give you more affordable coverage, but you really have to figure out if it can work for you. So anyway, so that basically, the slides are just to give you like an overview of your different options. Everyone has to navigate things a little bit differently, obviously based on where you are and what your kidney journey is like, but insurance is very important, and it's very important to stay on top of what is happening with insurance. I've spoken to quite a few people who are surprised by expenses that they come across because they never thought to ask about certain things. So it definitely behooves you to stay on top of that, to ask questions continuously, because things also may change with your coverage. Especially during this year, there's a lot more legislation that is going to impact the kidney community. And with a lot of these changes in legislation, there are going to be a lot of changes in insurance, especially with Medicare. Hopefully a lot of it for the better, but we're not sure. So it just behooves you to stay abreast of it. RSN is very good about keeping you abreast of what's going on with advocacy work and changes to insurance. So make sure that you keep in touch with Lori and with Renal Support Network in general and all your resources, and be your very best advocate. Okay, so
thank you, Sasha. That was a very wonderful presentation. And, you know, I just wanted to, I didn't tell people this, but I think it's really important that Sasha had a kidney and a pancreas transplant at the same time, right? You had type 1 diabetes.
I did. Yes.
And you're doing great, huh?
I am. I'm doing very, very well. And I'm very, very thankful for that. And also I did have to, that's another thing I should mention. I don't want to get too much into Cher's time, but also be very careful. Make sure that you ask questions about if you decide to get onto more than one list, like I did. Now, California is a state where there's more than one OPO, which is an organ procurement organization. There are 57 across the country, and most states don't have more than one, but California does. So I was allowed to be on 2 lists within the same state. But make sure that your insurance will cover all of the costs involved in getting on more than one list. So
thank you, Sasha. I have some barking dogs right now, but it's my pleasure to introduce Cher. And Cher Thomas, I've known Cher for, I don't know, almost 2 decades, I think. And she's an advocate. She's fierce. And she's had to manage a lot of medication. So, Cher, let's hear what you have to say.
Thank you very much, Lori. And thank you, everybody, for giving me a chance to share my story. I'm going to go in a little bit more depth about my history. Whenever I was diagnosed in 1997 with chronic kidney disease. I was already 31. I was already married. I already had a career. I was a registered dental hygienist. And part of my credentials and my training were learning about pharmaceutical medications, because I would be reviewing those with my patients, and about nutrition as well. But whenever I was diagnosed, it was a new challenge, because then it was me. But at the time I was diagnosed, I was very physically active, and I even did jazzercise about 5 days a week. Now, people who are younger here, you should Google jazzercise and get a little chuckle, because it was a good way of exercise, but a little crazy. I was also going to college at night, and I planned on eventually going to dental school or being a teacher. And then, surprise, as many of you have had, it was not in the cards for me. I had a detour, and I started having some unusual aches and pains that moved all around my body. And I went from taking 0 prescription pills a day to popping NSAIDs like they were crazy. So, anything I could get my hands on to get rid of the pain, ibuprofen, Motrin, Aleve, naproxen, aspirin, you name it, I was trying everything. And I thought that I might be insane. At 31, nobody should feel that bad. And I finally sought medical treatment. And I found out then that I was at stage 4 kidney disease. I didn't really know what that meant, but, I'd learned about the kidney in school, but I didn't know the stages. And then I also found out that I had an autoimmune disease called ANCA-positive vasculitis. And it comes with some antibodies, not the antibodies that Lori was mentioning earlier. It comes with autoantibodies. And these autoantibodies were attacking me, they were attacking my kidney and they were shutting things down. And that's a little different than a lot of people here. I didn't have diabetes. I didn't have high blood pressure. But my journey started with chemotherapy because we had to shut down my immune system from attacking my kidneys. And it was an experience, I might say. One, I had to first learn how to start taking pills every day. And back in 1997, my cell phone kind of looked like a walkie-talkie, and I do not remember there being any options on it to set alarms. I mean, it was like you could use it as a sinker. It was really big. And I took my pills. I was working and I took my pills 3 times a day, basically. I took them in the morning, I took them during my lunch break, and I took them at night before I went to bed. And I had to go cold turkey on the NSAIDs, and I was already feeling pretty bad. So it was making me a little irritable. The treatment was 60 milligrams of prednisone every day. And as Dr. V mentioned earlier today, you know, the way that prednisone was used 20 or more years ago, it could really, they used it a lot. And in my circumstance, I needed it. But it was the difficult thing to adapt to. And I also started taking an oral chemotherapeutic drug called Cytoxan. And that was not a piece of cake either. And these medications caused me to swell, right? Because my kidney function wasn't working well. And then my blood pressure went up. And so they prescribed diuretics. And then, of course, you can't take a diuretic without taking phosphorus, right? I mean, if you've had kidney disease anytime at all, you know what comes next. And then the diuretic wasn't pulling off enough fluid and my blood pressure was up. So then I was prescribed antihypertensive medications, and that made my mouth dry. And, you know, one thing after another, after another, after another. And ultimately, my GFR kept declining. That was the bad thing. And I was throwing up every day going to work. I had to pull off the side of the road. And finally, one day I said, stop, that's enough. I wasn't giving up on life, but I was giving up on chemo. And it was a pretty uncomfortable place to be. But my doctors talked me into trying one more thing. So they put me in the hospital and they gave me IV chemo, the same medication, and they gave me prednisone pulse therapy, which was 1,000 milligrams of prednisone a day for 3 days in a row. So a total of 3,000 milligrams of prednisone. It was a good thing that they admitted me into the hospital, but guess what? That caused my autoimmune disease to go into remission. Yay! Unfortunately, what it also did is it pushed me over into ESRD. Yes, my kidneys have failed. And so my nephrologist at the time recommended that I start PD. I looked into it. I did a little investigating on my own. I watched a videotape and talking about dating things, right? This was 23 years ago. I started taking medications for somebody who was on dialysis. I will be completely honest. I hated taking binders. They were chalky. I took them, but I really just didn't like it. And I learned things like you shouldn't take a diuretic after 5 p.m. or you're going to be up all night in the bathroom. And I learned that you probably shouldn't take your prednisone after 3 p.m. or you're going to be up all night. And I learned that I probably shouldn't have caffeine after 3 p.m. or I'm going to be up all night. And talking about being up all night, then I started worrying about how I was going to pay my bills. So being on chemo and throwing up like I was and going to the doctor took a lot of time away from work, but my medications were expensive. I didn't qualify yet for the Medicare ESRD assistance yet. And so it was a challenge. And if it wasn't for my parents, I would have had to file bankruptcy. And once I was on PD, though, I started feeling a lot better. And but I was still physically, I was feeling better, but I was mentally, I was worried about my bills. And so I did go on an antidepressant for a short time, about 3 months, and then I was able to adjust to everything. But that was another medication that made my mouth dry. And after a year on PD, I was feeling pretty good. I actually went to the Super Bowl right before my transplant, and my brother donated me a kidney in March of 1999. During my transplant workup, I was offered to be on a drug study program. And what it did is it allowed me to get a couple of my immunosuppressive meds and not have to pay that copay for my prescription immunosuppressants. And I jumped on it. I was like, hey, I'm trying to pay down these other bills. This is a good move for me. And it was an opportunity that within the study for me to be on lower doses of cyclosporin. And to this day, I'm still on cyclosporin. I did have sticker shock, though, whenever I went to the pharmacy the first time after my transplant, because one of my antiviral meds cost $500 copay every month for the first 3 months. So retrospectively, I should have gotten on the phone with my social worker, but I didn't know any better. So again, my parents swooped in and helped save the day. 22 years later, I met Lori. I wish I would have known her whenever I was going through chemo and PD and everything else, but I did meet her, and I had already found an interest in writing and speaking and becoming a patient advocate. And whenever I met Lori, it was like, where have you been all my life? At least for the last, let's see, I've known you about 20 years probably. So for the last 3 years, I'm like, where have you been? But so here I am 22 years later, and I have a new diagnosis. I have a new autoimmune disease. The old one didn't come back. I had to come up with a new one. And what it is it's called antiphospholipid syndrome, and it made me have a blood clot. So I'm on Eliquis now, and I want to wrap myself up in bubble wrap so I don't accidentally cut myself. But I find myself in a position learning about an autoimmune disease that I didn't know much about. And so every day I'm learning and asking questions and trying to adapt to something new. And that's what happens as we get older. You may have a new diagnosis of something that is related to your kidney, or it might be something completely different. For one, whenever I take my pills, whenever I first started out, I would take my pills one at a time. Whenever I took the prednisone, I would cry because it would taste so bad. But what I do is I arch my tongue up and I put the pill right on top of the tongue. And I take a swig of water. It doesn't matter if it comes from a straw, a glass, a bottle. Everybody finds the thing that works best for them. And then for me, I think I'm a little crazy, but I give my head a little bit of a shake. And it helps me get it off my tongue. You don't want to throw your head back because it can actually go into your windpipe. And that's not a good thing. But as a hygienist, I know that your medical team might refer you to go and see a speech pathologist if you're having trouble taking your pills. And it may be that you actually have a gag reflex. It may be that your mouth is too dry, which happens with a lot of people who have fluid restrictions. Most of us here at one point in time have maybe been on a fluid restriction or taken a pill that dries your mouth out more. And it can be difficult to swallow those pills, and it can affect your digestion too. So having saliva and being able to swallow pills is an important part of our care. You have to be sure to ask your doctor for help if you're having trouble with that. For me, even today, every once in a while, I still get a pill stuck whenever I swallow it. And I'll get a little piece of bread and take a bite or a cracker. And that's what medical professionals recommend, that you take that and it helps it go down your throat. Now, today, I'm not in college, but I am still constantly learning. I didn't become a dental hygienist or teacher, but I worked to develop skills where I could become a continuing education provider or be able to write. I've been published in several dental professional journals. And I'm still exercising a lot. I do it with Renal Support Network now. But be sure, if you're having trouble swallowing your pills, remembering to take them, this is something, it's important. It's important for your survival, and you need to be sure and ask your medical professional about it. Thank you again.
Thank you, Cher. I have a quick question before we bring Dr. Viacana on, but I wanted to get you both up here real quick because we had a couple of things. I want to know, how do you remember to take your medication? Go for it, Sasha.
Oh, I have a pill box, and without that pill box is my existence. If I didn't have my pill box, I would be a mess. So I have to look and make sure that because my mind is always a foggy mess, that I did it. So that keeps me structured.
Okay, and do you put a reminder in your phone, or is it like brushing your teeth?
I use an app. I use a medicine app. It dings each time I'm supposed to take medication. And it keeps dinging until you turn it off, which is also helpful and annoying. So it's both, yeah.
What about you, Cher?
By now, it's autopilot. I know when it's time. It's like my dogs. Whenever, it doesn't matter what time of the year it is. My dogs know whenever it's time to eat. In my head, I'm the same way. I know whenever it's time to take it. The challenge that I've had is I'm the single caregiver for my mother, and she has to take pills. So what I do is I remember to take mine, but in my phone, I have reminders for her to take hers. And I've helped her learn to use a pill organizer just like I do.
Well, and I totally agree with you, because as we get a little older, like Cher mentioned, we can't blame everything on kidney disease. There's just the aging process. And I never want to forget my meds. So I have bought little individual plastic containers with morning and night on it. It's that pill container. But I actually take them at night because it's very easy for me. And then I put it on the shelf for in the morning. And it's really good because then I remember to take it in the morning, because sometimes you think, did I just take my medicine? Did I just take it? And so it gets really frustrating, because you're like, well, and I don't know about Dr. V is going to come on and can answer this, but if I don't think I've taken it, I just take it again. I would rather do that. We have a couple of questions. They use applesauce and pudding to take pills. I totally agree with that. When I was a kid, my mom used to have to brown them up. And then there was also a question about, after your transplant, about 36 months. And there has been a law that's going to be passed. I don't think it's in effect yet, for the lifetime immunosuppressant drug bill. And after 36 months, we lose our Medicare. But this bill will allow people to have access to their transplant meds. And that's really a big win for everybody. The only issue with it is a lot of us lose our health insurance. So we still need to see the doctor for the lab tests and the prescription. And as Dr. V talked about in his earlier presentation, that, infection and other problems are what get you with the transplant. So we need to have insurance, and we're lucky that the Affordable Care Act is now available. Open enrollment's going to be coming up again, and really you have to be an insurance ninja That's what everybody has to be,
I
because
definitely do. Yes, 100%. Everyone listen to Lori.
well, and what's interesting is Dr. V also presented a slide that in other countries, they have a little bit better survival rate of transplants. And I bet you it's for the countries that have, guaranteed insurance, because we get calls all the time about people, just gasping for air because they can't get themselves covered. And I remember the olden days. I keep talking about that. I must be becoming my grandmother. Is that, there was a law, I mean, until, the late 1990s, if you had a pre-existing condition, they didn't even want to touch you. So you basically were left to either, work for a company if you could get a good job with insurance, or you had to go on disability and spend down. So we have so far to go. And I think everybody who's listening right now, you need to, talk to elected officials and let them be aware of it, because I mean, over 100 million people in this country have a chronic illness. So don't think you're like alone on this. And nobody should, go into bankruptcy just because they have a diagnosis. That's my personal belief. And I feel like it's just so sad to see it. And also, people don't go to the doctor because they don't want the diagnosis. So that's a good way to keep your head in the sand and then end up at the ER. So, well, I thank you ladies so much. I'm going to bring on Dr. V here when I see his picture. I don't think there were any other questions in the...
I have to further support what Lori said. Don't think that you can't talk to your legislators. They work for us. Talk to your legislators, and don't be fearful of that. We have to reach out and let them know that we need legislation that supports us, helps us.
And I want to follow up before we get into Dr. V about, the transplant meds, because I mean, this kills me. The only way to really keep your transplant viable is to keep taking your medication, to keep a constant level of medication in your bloodstream. And I happened to see a post last night on one of the threads, one of the Facebook discussion groups, is my tacrolimus is 2.3. How do I make it go higher? And I'm like, he's asking a group of strangers on the website. And I'm like, well, number one, take your meds, but you should ask your doctor, not, a group of patients, how to get your tacrolimus level up. But they can tell, if you've been taking your meds based on that level. So I'm going to bring Dr. V up here. And before we get started, would you just make a little comment about that? Can you tell when people aren't taking their meds?
In general, yes. But sometimes it's a little subtle at first because everyone's different. And, if someone doesn't take them right for maybe a couple days, not much happens actually. And the same would not be true for someone else. So there's times when someone might be skipping on the weekends and they come and see us and things on the surface look okay and I don't say anything. And that just further validates whatever is going on with them. And then they start pushing it even more. They might take more days off. And before you know it, there's obviously a florid issue. But I mentioned that in the morning, I didn't specifically name the test, but there are tests nowadays that can tell you before maybe that things are brewing before, when it's not that obvious. But yes, sometimes we're fooled as well. Sometimes I'm thinking that's the last thing I'm thinking of because I know the person, I feel that they're responsible, but it can happen to anyone really for different reasons. And so yes, we could tell, but it might not be as obvious.
You need a crystal ball to know about everybody. Yeah, and I've heard stories of people who didn't take their medicine for a while, and then they got a cold and it took their kidney out. Mm-hmm. It just knocked it out. Mm-hmm. There was nothing they could do. They went in such super fast rejection. Mm-hmm. They didn't know what hit them. So that is my PSA to take your meds, become a professional pill taker like I am. And a shout out to our corporate mission partners for making this happen.